Perfect. So, welcome to episode 2 of our Power Hour series. It has been a privilege for me to help run these sessions. For those of you who are joining us for the first time, welcome, and I hope you really enjoy this next hour. And if you were there for episode 1, I hope you found it as amazing and enjoyable as I did. That was the session on the e-portfolio. It's accessible. It'll be in your emails. It's live. It's on YouTube at the moment, so you can access that episode as well. It was run by our near peer fellow from Plymouth, Motaz, and yeah. So this is episode 2. Today's episode is going to be all about primary care, and just want to introduce the speakers for today. So the speakers are Kevin. Kevin Chatard is one of our new near peer fellows. He is taking care of the GP trainees in the Bristol patch. I'm really glad to have you, Kevin. Thanks for agreeing to do this session. And also
Problem.
we have Natasha, who is the near peer fellow in Somerset, and she is also valued member of our team. So I'm just going to give Natasha a couple of minutes, just a quick introduction, Natasha, and then back to Kevin, and then Kevin, you can take over. But welcome again for those who are joining, and I hope you have uh, um, a, um, a good time during this next hour. Natasha.
Hi, so yeah, as Isaac said, I'm a GP and a near peer fellow in Somerset. So I'm the near peer fellow on a Wednesday, and then I work as a salaried doctor 2 days a week. So yeah, along with Kevin, we're going to be running this session today, just to hopefully have a bit of a think, a bit of a reflection about how primary care might differ from secondary care and how it fits into the NHS.
Great. I'm
Kevin.
also, yes, no problem. Thank you. Thanks, Natasha. I'm also Kevin. I'm also a near peer fellow. Like Isaac mentioned, I'm in the Bristol patch, and I'm also a salary GP in North Somerset near the Western Supermare Hospital. Um, Thank you all for joining. I think we'll get started with our presentation. Natasha, do you want to start things off?
So we can't see your screen at the moment, Kevin. Do you want to just reshare? So yeah, while Kevin's doing that, the reason why I was quite keen for this topic to happen was the when I joined GP training going back a couple of years now. Um, Even though I joined GP training and I had attended my GP practice in the initial weeks, there was still a lot for me to learn about and understand what how primary care actually worked. Because coming from where, so I trained back in India, and primary care, as you can imagine, is so different to what it is over here. So that's why I thought this session might be useful. And before Kevin starts, one more quick thing. This session is going to be super important for your AKT. I've had a quick look at the slides, and there's quite a few things that bits of information that might be asked in the AKT exam as well. So keep your eyes and ears open. Over to you, Kevin.
Thank you very much, Isaac. Yeah, definitely will be on the exam in terms of the AKT. Can you see my slides now? Or?
Yeah.
Right. We'll just start with a question. If you could see that Slido QR code, we are trying to make this a little bit interactive. If you could use your phones maybe to scan that QR code, and let's see if this IT will work as well. I'll just give that a couple of minutes. And in terms of questions, there we go. What words come to mind when you think primary care? And some people are saying family doctor, GP, community. First review, absolutely. First point of contact, yeah. Continuity, yeah, definitely some themes there. I'll just give that one more minute. Well-rounded, yeah, that's a nice one. Jack of all trades. Yeah, definitely. I do consider myself a jack of all trades. Referral to secondary care services. Yeah, we definitely do that a lot in primary care. Health promotion. Great.
Really interesting thoughts coming through, isn't it?
Yeah, that definitely. It's on the first questions. Good. I think I might just stop there and I'll see if we could ask another question now. So what's your biggest unanswered questions about working in primary care? And we appreciate that you're now starting at ST1, but you've gotten into GP training. Well done. But we want to know what's your unanswered questions. Your changing scenario. Managing uncertainty and risk. Yeah. It's really isolating or working alone. Yeah, we definitely touch on things like that later on. A very topical issue. Will there be jobs in the end?
Just to very quickly answer that, is it isolating working alone? It you can make it what you want it to be. If you're an introvert, you can make it as isolating you want it to be. But if it matches your personality type, you can make it what you want it to be.
Yeah, I think to answer that, Isaac, I think I agree with you. If I would say I'm an ambivert. There's another term now, and you could make it as isolating as you want, or you could, knock on your door, and it depends on where you work as well, where you will have MDTs or have a chat with other GPs, other clinicians, other mental health teams, and we'll talk about other clinicians and other team building and so on. So I think I can't see any other questions there. So we will definitely be touching on some of those sort of themes that's come out there. Natasha, is there anything else you wanted to say, or no? That's fine. I'll move on to from there. Right.
So yeah, we thought we'd talk a little bit about how primary care fits into the NHS in the UK. So the picture on the left essentially shows the kind of four main components of the NHS. So you can think of it as primary care, which is obviously the area that kind of we're all working towards being part of. Secondary care, which a lot of you will be in placements for at the moment. Tertiary care, which is kind of one above secondary care, is the easiest way to think of it. So those more kind of specialised services, so trauma centres, burns units, the places kind of people get referred to from a secondary care hospital, and then working closely with kind of primary care, community health, so things like your district nurses and your health visitors. The picture on the right is sort of just a very tiny little cutout, but it's of the southwest of England, which is where we're all working now. So whilst it's kind of a national health system, the NHS, particularly for primary care, is regionally organised. So you can probably see in the kind of tiny little circles, but your GP practices will sit within something called a primary care network, which is basically a group of GPs. And then they will sit amongst something called an integrated care board, which is a kind of bigger provider of health services, which will include multiple PCNs. And the reason that you kind of don't need to know the ins and outs of this, but it's important to be aware of, is because whilst things are kind of nationally arranged, actually in primary care, things are commissioned on a local level. So actually, primary care can kind of be responsive to the needs of its local population, and they can have kind of a bit of say about kind of what services they run and how they're run. Have the next slide, please. So this came up actually in some of your words about primary care, quite similar when people said kind of first point of contact. So you might hear the word kind of front door being used for primary care. So it's sort of seen as the front door of the NHS. So for a lot of patients, it will be the first point of call if they've got a health problem. So they may come to you with acute problems. Obviously, ideally, not super acute. Ideally, they'd go to A&E if it was really urgent, but often they will come to you, and you'll have to manage those things and get them referred on. A big part of primary care is things like chronic disease. So doing kind of long-term kind of condition management. So thinking about things like diabetes or asthma. As people mentioned in the kind of word slide, referring to specialists and secondary care will be kind of part of your day in primary care. And the other part, which is kind of on a bit of a longer term sort of thought, is health promotion. So actually a really big part of GP is also thinking about preventative medicine. So, you know, what can you do to prevent your patients getting ill in the first place? Next slide. So we thought we'd take this opportunity to ask, I'm going to ask Kevin a question to see kind of what his thoughts are on this. So I was just wondering, how do you think primary care differs to secondary care?
Yeah, I think going back to some of the words that some of our people have mentioned as well, the differences of primary care. I mean, I like to think about primary care as sort of the first point of contact for sort of most health concerns, you know. And if you contrast that to sort of like secondary care, you know, I think that's where you get more of the special, like you mentioned, these kind of specialist services, usually following a referral from another setting, you know. Primary cares, you know, the themes are sort of preventative, you get your screening programs, immunizations. We're at the front door, like you mentioned, we're diagnosing and managing a lot of our chronic conditions and acute conditions. And we're sort of gatekeepers in primary care, you know, referring to secondary care. And I like to think of it as being accessibility. You know, the themes I think about the primary care as accessible. We're having continuity when we're seeing all of our patients, and it's holistic, you know. And while secondary care is a bit more episodic, you know, you go in for a one-off hospital treatment. It's a bit short-term, very hospital-based. You're getting much more investigations that you would get than compared to primary care. So you know, things like angiography and, you know, these really specialized investigation PET scans that you wouldn't really get in primary care. Some GPs in certain PCNs or ICBs, like Natasha mentioned, may have access to MRIs and so on, and CT scans. It kind of depends on where in the Southwest you're working. And again, in secondary care, you're dealing with more complex management beyond the scope of GPs in primary care.
Yeah, I was also going to make a quick comment. I was just going to say, I think as primary care clinicians, you will be using your, and I don't mean in disrespect to secondary care colleagues, but you'll be using your analytical minds and your brains a lot more because you don't have access to immediate investigations. You will have access to investigations, but in that moment, you still have to access different parts of your knowledge base in your memory to see what could this picture actually be without access to immediate investigations. And the analogy that I use in terms of, like you said, gatekeepers, I think of it like a dam essentially, that we are kind of holding off as much as possible of. I think the statistics say that we see about 80% of the NHS appointments are primary care, and then we let through only a few to secondary care. Sorry, just want to make that comment.
Yes, thank you, Isaac. Yeah, that definitely makes a lot of sense. Yeah, we definitely take on the majority of patient contacts in primary care compared to other services. So another way of sort of differences between primary and secondary care is, and somebody has sort of asked as well, is sort of dealing with uncertainty. And this image was actually taken from the Oxford Handbook of Clinical of GP Practice, sorry. So not the cheese and onion is what some people call it here. So this is the Oxford Handbook of General Practice, and it's actually a good resource to have on hand if you could find either a PDF or buy a copy yourself. And this is Marshall Marika's, he was a GP and a researcher as well, and he sort of contrasted the role of generalists versus specialists. If you think about GPs as we're excluding the presence of serious illness or serious diseases, and you know, in secondary care, they're trying to confirm the presence of serious illness or diseases with specific tests and so on. So, like someone mentioned, we are tolerating a lot more. We try to tolerate a lot more uncertainty in managing patients' undifferentiated symptoms. and while specialists will try to reduce the uncertainty by investigating until a diagnosis is reached. So again, contrasting that, we're exploring the probabilities of seeing patients with a relatively low incidence of serious disease. And when we refer them on to secondary care, they are going to see a different pre-selected population, because we've seen patients with a probable higher incidence of a serious disease because we've ruled in and out, certain red flag features, for example, patients with weight loss and, night sweats and signs of cancer, for example. We're going to refer that on to specialist care. So back to us in terms of GPs, we're trying to marginalize danger and recognizing these danger signs or red flag features, even when the diagnosis is not certain. While the specialists, they're trying to marginalize that error. They're trying to get as accurate as possible for diagnosis and appropriate treatments. I hope that makes sense. So moving on to sort of primary and secondary care, I thought I would talk a little bit more about, the sort of job roles in primary care and a bit of who's who. So actually, when it comes to what is primary care, and obviously that's the main talk of today, general practice obviously is what you sort of might think as primary care. But in the UK, actually, there's about 4 pillars of primary care. So besides general practice, we have dental practice as well. Dental practices are also part of primary care. We have opticians or community opticians. So when you think about things like Specsavers and those sort of things, they also form a big part of primary care as well. And then we have our pharmacists, the community pharmacists, so not the ones in the hospital. They also play a big part of primary care as well. And in terms of the sort of funding and contracts, which we won't really go into much today. So I just wanted to highlight that those are your 4 pillars of primary care and who we will work alongside as well. So we'll focus a little bit more on the actual who's who in general practice, particularly today. So obviously we have our GPs or general practitioners who obviously will sort of help diagnose and treat and coordinate care, and like I mentioned, gatekeepers to specialist services. Now you may ask, well, who else is working with us? So we'll have practice nurses. So obviously our practice nurses, if you haven't been into a GP practice yet, they're basically going to help us with dealing with kind of long-term conditions. So a lot of our practice nurses help with, diabetes, asthma, COPD, vaccinations, wound care, and that sort of thing. We also then have healthcare assistants who will be supporting, these practice nurses and the GPs. They will kind of help us with doing blood tests, ECGs, dressings, and even giving lifestyle advice. Smoking cessation clinics will be given by the HCAs. Then we have practice managers. So practice managers are basically these non-clinical, they sort of oversee the business side and operational sides of the practice to help smoothly run things. It's always needed. And then we have our backbone, which is the reception admin. So in terms of our administrators and care coordinators, they're going to be helping with triage, accessing appointments and records and so on. So beyond that, in terms of the core sort of colleagues in the actual GP surgery itself, we're also going to have a bit of clinical pharmacists with us as well. Some of them obviously may be working in community pharmacists, but actually in your own GP practices or within your PCNs, you may actually have some clinical pharmacists. And then you could also have some advanced nurse practitioners or physician associates. So they obviously are supporting us in sort of diagnosing and treating. It depends on, they usually tend to deal with more acute scenarios or acute illness, but depending on their level of training and expertise, and they may do have certain masters, for example, they may deal with a bit more. And they certainly help with things like home visits. Then adding to our team, mental health practitioners. So obviously they're going to help with sort of mild to moderate mental health problems, depression, anxiety, and serious mental illness. So going back to a bit of the administrative teams, we have care coordinators who might be helping with coordinating care for patients who are a bit more complex and need to navigate between different services. So, for example, moving between different primary cares or even coordinating care with secondary care. We have then social prescribers and link workers. So if you don't know much about that, so they would help with things like non-medical needs, things like housing, loneliness, which we know is a very common things post-COVID, sort of finances and lifestyle, weight management and that sort of thing. Social prescribers and link workers can help support us with these sorts of scenarios as well. Going back to some of our clinicians, we could also have first contact physiotherapists. So they will definitely help with seeing sort of urgent cases or musculoskeletal assessments, and they sort of do the first assessment and then decide whether they need just self-care or any other secondary care services or even community services, which I'll get on to. So in contrast to that, so community physiotherapists, so that will be within the community, so it's not in a hospital. They be supporting patients with musculoskeletal problems. Then we have in the community, again, to be contrasting other services here that are not particularly may not particularly be in general practice, but we're working alongside. So district nurses, so these are registered nurses who are sort of helping in the community to deal with sort of housebound patients, and they also help with home-based nursing, and we'll get a bit more into that. So podiatrists are another subset of therapists who mostly deal with below will be essentially the feet. They deal with anything to do foot related that the physiotherapist could help out with, the podiatrists deal with. Community midwives. So these are midwives who are obviously not in hospital. They're in the community and they will help with things like antenatal and postnatal care. Health visitors. So health visitors are also nursing colleagues who are in the community. They deal with child health, safeguarding problems, and family support. Occupational therapists. So you might have met some of these in secondary care as well. So you also have occupational therapists in the community to make assessments of our patients. And then also in the community, we have things like the hospice and palliative care teams. Now, sometimes they're in the community and sometimes they are driven by, what's the word? Well, essentially they're in the community and they have different funding streams as well for palliative care services. And they obviously deal with sort of end-of-life coordination and work with us in general practice. So, sorry, no, you wanted to.
No, I just want to say, just very quickly to that slide, and this distinction that Kevin has just very beautifully laid out is so important for us as primary care clinicians to understand, because in secondary care, all of this is in their minds, all of this is one big blob. But it's so important to kind of make that distinction and kind of understand whose role is what. And yeah, I just thought make that comment. Thanks, Kevin.
Yes, thank you, Isaac. And this is not an exhaustive list. This is just what I thought was really relevant to you moving into general practice. There's much more other roles and other different types of clinicians to learn about when you start working with us. So you might ask, well, what services we actually do provide, at our GP practice. So it actually does get a little bit contractual in a sense. We didn't really want to talk a little bit much about contracts and this sort of thing. But I sort of wanted to just highlight that there's different layers of services that are available at your GP practice, and it's all depending on funding, etc., which I won't get into. So the sort of main essential services, starting with, are your kind of main GP services, which tend to be within what we call core hours, which will be between 8 a.m. to 6:30. And that's obviously what we're doing, is diagnosing and treating and managing acute and chronic illnesses. We're dealing with health promotion and preventative care, basic contraception, and actually postnatal 6 to 8 week check for women. And then if we were to break down a little bit more into essential and additional services, so I won't go too much into why this happened, but it has to do a little bit into the history of the NHS and how general practice was set up, in terms of contractually. We were GP partners, for example, have the actual contracts to provide GP services through NHS England. And essentially, we have the contract to provide essential services, which essentially lays out that in the green box. And then we are also expected to provide additional services, so which technically a GP practice can opt out of, but that's things like providing cervical smears, vaccines and immunizations, and child health surveillance. And then you might ask, well, what else is there? So technically, we have another layer called enhanced services. So, this is something that can be nationally agreed. So NHS England can write to GP practices and say, we recognize that GP practices could probably help out with this, or it could be at a more of a local level. So for example, in our last picture with that Natasha highlighted, different PCNs and ICBs, they may realize in a specific part of Bristol or a specific part of Devon, for example, there was these services that were lacking and it wasn't available in secondary care, and whether GP practices can provide this service. So what I mean by that, so specific things like learning disabilities. So patients with learning disabilities obviously have a lot more needs. Patients with dementia, so we're trying to support patients with that. Substance misuse, sexual health, weight management is a very hot topic at the moment. Everyone wants Monjaro. So how do we provide care for that? Coils and implants. So these are sort of locally enhanced services that could be provided. Minor surgeries and procedures like joint injections for musculoskeletal problems or removal of skin lesions, and even some vaccinations, and wound care. And lastly, we have, services not provided by the NHS and not contractually that we're supposed to be dealing with, but we will still provide anyway. And that's things like medical reports. And medical reports are things like insurance, for employment, for driving. So things like heavy goods vehicles, patients who drive heavy goods vehicles, they need to go through specific assessments to get these driving licenses. Similar with taxis, patients will come for letters for school or employers or for housing, fitness to travel certificates and travel vaccinations. And technically these are not NHS services, but we still provide it anyway. And these do attract a fee. I don't know if there was any questions, or Isaac or Natasha had anything else to add with regards to that.
Yeah, I think with that last point, I think it's just to highlight that it's really important when you go on to your GP placements that you understand the things that the NHS doesn't cover, because that it will come up where patients during your consultation will say, oh, could you just quickly sign this, or can you just do me a quick letter? And I think when you start GP and you don't know about it, you may think, well, that sounds reasonable, and you might, feel that you can do that. But it's important to understand that, the practice will have their own list of fees and charges. So if anyone ever asks basically for something, additional, it's important to just check with your practice manager or one of the partners or someone even in the admin team, because there'll be normally kind of set pathways about how those things get arranged.
Yeah, And like I put in the chat as well, that that understanding this is quite important for your AKT as well. This particular slide, you will get questions on this for the AKT. So when you do go for your practice visits, when you go and visit and meet your ES, take time out to just talk about how the practice is run. Go and meet your practice manager. They are quite knowledgeable as well. And from an if not to understand primary care, at least from an AKT point of view.
Yes, thank you, Isaac. So, Natasha, in terms of like things that you were already kind of alluding to this as well, but was there anything about your role that you kind of was any things about your role that when you became a GP that you were kind of surprised about?
Yeah, so I think definitely kind of a bit what we've touched on about the kind of variation and range of services. I think kind of going into GP, I think I was sort of used to, I suppose, maybe as a patient myself, only seeing kind of, you either see the nurse for something or you see a doctor about something. And I think especially as time goes on, those additional roles. So, when you go in, actually, if it's for a medication review, then seeing a pharmacist is, potentially better than a GP in some cases, or for some acute things that actually a nurse practitioner or a paramedic might be used. So I think definitely the kind of range of kind of services and people available at a GP is much wider than just GPs. I think day to day, I think the job involves a lot more kind of social problems and kind of more, those kind of wider society problems really than just purely clinical problems. And I think that's a really important thing when you're working in primary care and going into it to be aware of that, in hospital, everything has a kind of medical diagnosis and, then a treatment plan. But actually, a lot of your time in GP, you'll be dealing with that uncertainty. And sometimes that will be that, people have got maybe a difficult life situation or something going on, and actually they're kind of looking to you for just kind of a supportive listen sometimes, and that you don't need to be able to necessarily kind of fix all those problems. I don't know, Isaac, did you have anything to sort of add?
Not particularly. I think you could quite summarize it quite well.
Okay. Next slide, please, Kevin. So sort of leading on from that, really, this slide was just to highlight the kind of importance of that wider context. So as well as your sort of day-to-day work in your GP practice, it's important to remember that you sit within kind of the wider NHS. So there'll be screening programs that are running kind of nationally. So things like the cervical screening program might be delivered by your practice, but it's kind of, the process and how it works is decided on a national level. Things like NHS health checks, so adults over 50 can often go to where I work. For example, it's at a kind of an old GP practice community hub type place that run these health checks where people can go and have their cholesterol checked and their weight and their BMI. And a lot of this ties into sort of public health type initiatives. So thinking about that kind of more preventative approach and how you can keep your patients that you're looking after kind of healthy and prevent problems happening. So you'll work alongside, there'll be kind of guidance for your specific practice. So often practices will have their own protocols and guidelines. So we'll have like a hypertension guideline and a CKD guideline, but most of those will be based on NICE guidance. And you'll definitely, if you haven't already come across it now during your GP training, something called clinical knowledge summaries will become quite common to you. So I'd really recommend getting in the habit of looking at that so that when you come across a condition, you know how actually kind of from a national perspective, you're expected to treat these conditions and investigate things. Because often, if you're kind of, when you're in GP placement, if you're thinking, oh, I don't know how to manage this, actually NICE CKS has a lot of the answers, and that will be what most of your seniors and things are working from as well. They're obviously guidelines, so we always say something called they're guidelines, not tramlines. So they're there to guide you and help you make decisions. They're not rules, so you obviously you're a doctor and you're allowed to say, actually, we're going to veer slightly off this guideline. But I would be a little bit cautious, especially kind of in your early days as a trainee, about veering too far off them. And I would sort of try and work as closely as you can in line with the national guidance if you can. There's also things like 2-week waits, which are the national kind of decisions about how different cancers should be referred for. So we in Somerset use something called See the Signs. Different areas may use kind of different things. That's just a computer program. But there's basically on NICE, there'll be different referral criteria for different types of cancer. So it's just important that you're kind of aware of these, and when you're going into general practice, that you sort of are aware these exist, so that if you see patients with things like a new anemia, you're aware that actually that does meet criteria to be referred to have cancer ruled out. Next slide, please. So in terms of kind of the sort of, again, the kind of wider things that you need to be thinking about, especially in GP, there'll be lots of things like social and safeguarding considerations to think about for your patients. So you're quite closely linked with kind of social care and social services once you're kind of in GP land. So that may be in terms of patients may want to talk to you about that they're thinking about going into something like a residential or a nursing home. They may already be in one of those, and you may be being asked to go and visit someone there. And whilst you don't need, you're not a social worker, and you're not expected to know the ins and outs of things, having some awareness of the kind of challenges that people might face in terms of kind of social care and accessing support, I think is important, because for patients, often the physical symptoms of things obviously will be a challenge, but sometimes the kind of social challenges, so if they're not able to, wash themselves or dress themselves at home, might actually be impacting them more day to day. So just having a bit of understanding that, there is a social care system in the UK, and that there is help available for people, which is kind of finance dependent, but just being aware that those things exist and where you might signpost people to is helpful. So most kind of areas, most councils will have a phone number. So I quite often am writing down the phone number for what we call Somerset Direct, which is the social care system in Somerset. And I think just knowing even a phone number or an email to be able to say, why don't you try ringing these people to talk about what help you can get, I think shows your patients that you're kind of thinking about them in a slightly wider context. Social prescribing is something that Kevin briefly mentioned earlier about the different roles. So there may or may not be social prescribers where you work. So I've worked in places where there was them, and now where I work, we sort of don't have them in such a specific way. But this is really thinking more about health and well-being. So there will often be some sort of social prescribing where you work, whether this is things like health coaches, who are people who can give kind of lifestyle advice and support. There may be things like, you might be able to refer people to local gyms or swimming pools. So again, you don't need to know the ins and outs of what is available. You just ideally need to know who you could direct someone to get more information. And there might be things like texts set up at your practice that you could direct people to. The next part about benefits, so that's again something that may come as a sort of surprise when you start as a trainee. You might not as a trainee be being asked to complete these forms, but you may see your supervisor doing them, and certainly once you start kind of a substantive role after training, you will be given these forms to complete. So these are things like if patients are applying for benefits for health reasons, as a GP, you'll be expected to complete forms explaining their medical history and how able they are to complete things like activities of daily living. There's also things like prescription payment exemptions, which you just may need to be aware of. So if you've got patients coming in who say that they can't afford to get things like medicines, there are various reasons that they might be exempt from paying for them, and there's a form they can complete. So this would often be things like if they're on benefits, but also there's some health conditions that if patients have got, say patients who are, for example, diabetic or got low thyroid, they're eligible for free prescriptions too. So it's just kind of worth being aware that not everyone in the UK will pay for their prescriptions. Safeguarding is a really big part of a GP's role, especially because you have that continuity of care. So you're potentially in a better place to pick up those maybe subtle changes about how someone is presenting or concerns that they may be raising. And you often will also know other members of the family, so you might kind of pick things up from a slightly wider context. So it's important that you do your level 3 training, which I'm sure has come up in things like induction. So that is kind of a nationally recognised level of training about safeguarding that all GP trainees need to do. And then every year as part of your portfolio, you need to make sure you're doing some sort of annual update and reflecting on safeguarding cases. Each GP practice will have a safeguarding lead. So if you've not had the opportunity at any point to sit in on something like a safeguarding meeting, then it is worth having a chat to them if you can, just to try and find out a bit more and to make sure that you understand the process where you work. Next slide, please. So I think we're going to move on a bit now from kind of those kind of clinical and day-to-day things within being a GP. So Kevin, are there any kind of non-clinical things that you think it's important to know about as a GP?
Yeah, I think there's lots of non-clinical things to know about. You really touched on some of the non-clinical things already. I think one main thing that when I was in GP training that I thought about was all of these IT systems. You know, we learn about all these IT systems in hospital placements and different settings. And then when I was visiting my trainer and different GP practices, I was seeing all these different IT systems, and I felt like, oh yeah, I need to learn about that one day. So I think we'll talk about that. So I think IT systems. So obviously there's lots of IT systems that you will learn about in your inductions for your hospital placements. And when you start GP placements as well, we will induct, or your GP practice will induct you as well into training about these IT systems. And I just wanted to touch on them a little bit. So in terms of the main IT systems in the UK, the main ones, and obviously you guys could pitch in as well if you hear others. There's an EMIS Web and then System 1, and the main sort of systems to manage patient records. So for example, in Swindon, and it depends on where you are in the Southwest, we'll have different IT systems. So for example, in Swindon they use System 1. If you move to a different PCN, then you use the EMIS Web. And again, but all in all, they do very similar things. So it allows you as a GP or a trainee to access the patient record, you know, record your consultation in there, prescribe medications, and make onward referrals. Those are the sort of main components of it in general. Now, then you're going to ask, well, what about other things? So things like documents and the interface between primary and secondary care. Now, you may ask, is there one IT system where everything can be seen from primary and secondary care? And I would say probably that's a good idea, but the answer is no, not everything joins up. And there may be other systems, for example, where I work, there's something called Connecting Care, where you can see some of the hospital systems and so on, but it all depends on where you work. But the main thing that we would use to see, for example, letters from hospital, if your patients had like we said, an inpatient stay or a short stay, letters from hospitals and services basically come to the GP practice via document, and we have admin staff that help us really crucially in managing these documents. We get loads of documents for all our thousands of patients registered with us. So the admin staff play a really important role in helping us to triaging and reading these documents, you know, and then assigning tasks to the clinicians to action these outcomes. For example, if someone goes into hospital and ends up with a heart attack, we need to code that and action any procedures. For example, if there's a discharge summary saying to do any blood tests or to monitor, essentially we need to action those appropriately and timely. I don't know if Natasha or Isaac had anything to add about that.
No, I was just going to say, I was just typing in the chat, but might as well just say it. I think that I have two top tips. Number one is try and like this whole IT is constantly evolving. There's new apps coming out. There's new systems. There's AQRX. There's different things that each PCN is adopting, especially in the world of AI. So if you want to stay ahead of the game, make your work easier, make your life easier, stay ahead of the IT. And number two is in terms of typing, and I told this to my particular trainee who I'm the supervisor for, is if you are not good at typing, please do a typing course. It'll save hours of your life.
Yeah, that's a really good tip.
I just wanted to add in about the whole thing with the IT systems. So I think it's important, obviously, a lot of you in hospital placements at the moment, and so I think it's really important to highlight that when you're writing letters, so especially things like a discharge letter, it's important to be super clear. So often the biggest example, the most common example, is that there'll be a box on the discharge summary that says any change to medication, and it'll have been auto-selected as no. And then that letter maybe goes to admin see no, and they might therefore not sort of flag it to the doctor. But actually then you look at the letter and you look at the list of medications, and they're completely different to the ones that they went in on. So when you're doing letters, it's really important that in the actions for GP part, or say different things, or plan for GP, to just make sure that what you write is really accurate, so that if there are things that the GP needs to sort, that the admin team can then get the GP to sort those things out, because it's super easy otherwise for things to get kind of missed.
Yeah, thank you. It's a really relevant point. Definitely one of our, definitely all GPs will face that. So that's obviously the main sort of clinical systems to manage your patient records. But you may ask, well, what else is there? Isaac already mentioned some other ones. So in terms of communication tools, so how do our patients, for example, as we mentioned, ITs are, I guess there's even some AI being used and being trialed as well. But what we also can be using is things like AccuRx. So AccuRx is another IT system which we can use to text patients or to help patients to, it's basically another online consultation platform which patients can then use to submit patient queries. So what are my queries? So if, for example, they may have a bit of a template. So if they had a cough and a cold, they will be able to type in these things, and the AccuRx might ask them specific questions and different red flag features, depending on how tech savvy the patient is as well. And then that can be triaged appropriately to offer them urgent appointment versus a routine appointment. And similarly, another platform that is commonly used is the e-consult system. So if you've been if you've probably registered with a GP practice and you're trying to make an appointment, there's methods in terms of phoning the GP practice, but they may ask you to submit an online form or an e-consult to basically make an appointment or make a query. Is there anything anybody wanted to add to that, Natasha or Isaac? So moving on a little bit about more IT systems, and you might have seen this around, and that might be the NHS app. It's definitely a big thing that's happening at the moment with NHS England. So what is it? So it's a free app which is secure, developed by NHS England to access NHS services using their smartphone or their tablet or even a web browser. So it was developed by NHS England and NHS Digital, which is another lower level to them. And the kind of main features is to book and manage GP appointments. So now that's if they're not using things like AccuRx or eConsult. Order repeat prescriptions. And again, each individual GP practice might have different policies or methods, but they could use many. For example, at my practice where I work, I tell my patients to get the NHS app and to order their prescriptions online. Patients can now also view their medical records. So, for example, instead of me telling my patients what the plan is, I might just tell them, if you forget, have a read on the NHS app and read what we talked about today as a bit of a reminder. They can also use the NHS 111 system to get some clinical advice on terms of their symptoms, where they may be at least signposted on whether they need to book an appointment with a GP or go to an emergency department. Interestingly, they can also give you a bit of a vaccination status as well. So COVID vaccines or any immunizations, the record will be there as well. And even receiving messages from your GP practice and setting things like organ donations. So why is that important to know? Well, it will obviously reduce admin load. And admin load is definitely a major contributor of our workload in general practice as well. Fewer phone calls for appointments and prescriptions if they can just fill out a form or use their app. It gives them more control over their own health if they can see their records as well. So it improves the access for younger patients as well and more tech-savvy patients. But obviously the challenge being that patients that are not tech-savvy are being digitally excluded. So that's why you have to, and that's another topical debate at the moment, that we have to make sure that all of our access is available in different ways. But it also kind of supports the continuity of their care because they could view their own test results and records.
I think it's just important to highlight with the fact that they can view the medical records, that you just need to be, that you should be doing it anyway, but when you're writing things, 5 years ago, 2 years ago, patients couldn't read what you wrote. So, if you were using abbreviations, or if they were kind of an angry patient and you maybe would write that in the notes that they were, angry or shouting, you have to remember that now they can read whatever you write. So it's really important to be really factual in your documentation on the GP records, not write anything that could potentially be controversial. But also to remember that if you're writing anything that perhaps is from like a safeguarding perspective, so if someone discloses domestic violence, for example, someone else could potentially see it on their NHS app if it was open. So there is the option to, at the top, for example, on emails, you can click hide from online record. So I think it's just important to be aware, because there definitely, when it first came out, was quite a lot of things that came back where patients sort of called in to say that this was written and that's not what I said. And yeah, so it's just being a little bit kind of, keep it factual. Don't write necessarily quotes, because then they'll say, oh, I didn't say that. And yeah, just try and keep the notes factual but true.
Yeah, thank you, Natasha. That definitely is a thing that is happening recently as well, because this is fairly new. I think within the past 1 to 2 years, they've been rolling this out. And yes, I think when you do start your general practice training as well in your GP surgeries, most likely your trainers will support you with deciding how much you put into the record, how you put things in the record, and importantly, like you mentioned, Natasha, with regards to safeguarding, what you do in terms of you can hide some things from the online records, and putting things like ghost consultations, etc. That will definitely will be something to learn about. Right. Natasha, I have a question for you. So how did you make, talking about that as going to your GP practice and so on, how did you make the most out of, your days at your practice as a ST1 or ST2?
Yeah, so obviously, well, you'll be in hospital posts, but you should every couple of months have kind of a day in practice, which will be up to you to kind of arrange with your supervisor or the practice manager at your ST3 practice. So I mean, these were kind of a great opportunity to kind of obviously go and spend a day with your educational supervisor. So, your supervisor, unless, something happens, will stay the same throughout your GP training. So it's a really great opportunity to kind of get to know them, because you'll be working quite closely with them for your reg year. So I would definitely utilise kind of getting to know them. And obviously, watching them do some consultations, kind of getting to know a bit kind of about how primary care consulting is different to that in hospital, because the kind of earlier you can kind of get your head around some of the concepts and the kind of models and frameworks used in GP, the easier you'll find those consultation skills when you get there yourself. Getting to know the wider team, I think, is really important. So Isaac mentioned earlier, when you're there, you can go and chat to people like the practice manager, the receptionists, the first contact physios. It will make your life a lot nicer when you then go and work there if people already know who you are. And I know some people in the kind of questions were talking about concerns about things like jobs and things. And whilst it's not guaranteed at all, because it depends if your practice then needs a new doctor, it's not uncommon for people to at least try and get a job at somewhere that they've worked at during training. So whilst you're not on sort of a long job interview, if you can make a good impression and show that you're interested, if you do like it there, then I think it is definitely worthwhile. So that's kind of the main things, I think. Isaac, do you have anything else that you
No,
did?
I was just going to say the last bit, what you had said about this could potentially be the place where you spend the rest of your life. So make the most out of your contact days.
Yeah. Just to add to that, I would say in my personal experience as well, one of the first things I did was sit down with the admin team sitting down with the medical secretaries, and that really made a big impact into where I worked. And into talking about job opportunities and so on, that really made an impact into where I worked. Me taking some time to sit with my reception staff and learn what they do, learn how they do things, learn how difficult their job is. Um, I would definitely recommend it when you sit in with your during your training days.
Right.
I
Thank
I think that was most of the presentation. So it's just if anyone had any sort of last questions or things that they wanted to cover.
Yeah, no, really, really good talk while people are putting their comments and questions in. So please feel free to turn on your mic if you're comfortable to speak or add questions in the chat box. But yeah, absolutely relevant and absolutely, it for me, when listening to both of you, it's almost given me like brought me back to those early days where I wish I knew this information before in the beginning of my ST1. So hopefully this has been like slightly giving you a taster to what to expect uh, and while you're working in the shadows of the hospital. Primary care is a whole different world, and so hopefully this has given you a bit of a taster. Some good comments coming in. People are saying thank you, very helpful. Thank you. Yeah. Any other questions before we close? We made good time, by the way. What I will do now is stop the recording, and then people can ask questions off recording as well if they need to. I'm just going to stop the recording now. Thank you all for joining.